Preparedness. I'm the pleasure of introducing the speaker this afternoon. I've known Mike for 25 years. If you know anyone around Orange County, you're going to know Mike if you're in healthcare, that is for sure. If you're from outside of Orange County, you're going to get a treat for someone who has the most dedication to hospital preparedness, EMS preparedness, and fire service preparedness. There's no one better than Mike Steingraus. So, Mr. Mike Steingraus.
I feel like I have to pay him for that. Jeez. Unfortunately, I have the after lunch crowd. Hey.
Hey, Mike.
How you doing? Good, good. Where everybody's just eating, they want to sleep, and then they straggle in at the very last minute. Well, welcome. Thanks for having me here. What my presentation today covers is resources, how we can manage those and how we request those, as well as trying to prepare for disasters. So when could outside medical resources be needed? Really all of these: fire, flood, earthquake, storm, transportation, accidents, terrorism. The grants all started probably about 11, 12 years ago now, maybe 13 years. So we've been getting money, and that all started because of terrorism. So all the hospital preparedness stuff, actually hundreds of thousands of dollars that have gone to each facility into preparedness all came from the terrorism aspect. And fortunately, we have not been hit, at least in this county, on that aspect. But I'm here to tell you one of my other jobs is I'm a terrorist liaison officer. And there's a lot of stuff that we kind of find out, because I also work in law enforcement, so I have a little higher level in that category, of things that you guys don't ever hear about that the FBI has stopped. It's actually staggering, some of the things. And some of them you do hear from. So we've been pretty lucky in that aspect. But the greatest threat I think that we have is what up there? The earthquake, exactly. We never know when that's going to come. I also help manage a disaster medical assistance team through the National Disaster Medical System. So I've been on a lot of disasters. I started doing this back in the 80s, and that makes me really old when I think about that. And my first disaster was in 1991, Hurricane Iniki. And of course I was at Katrina as well too. So I have lots of experience and stories from all of those, but all of those, it seems like those people are kind of get a little bit of a forewarning that hurricane, tornado's coming. The big earthquake, we're not going to know it until it comes. So we'll all be jumping under these desks in a few minutes, or tables, I should say. And it's always amazed me how people don't leave. I don't know, if somebody told me that tomorrow there's going to be an 8.3 earthquake here in Southern California, I think I'd be inclined to leave. Yeah, who said that? Just joking, it's not going to be here tomorrow. Throughout a lot of disasters that we have, one of the things that we know, patients will seek medical care, what's most familiar to them. A lot of them will go to the closest place to seek that medical attention. And during the terrorism attacks, if any of you have had any of my WMD, Weapons of Mass Destruction classes, we talk a lot about this. I like to pick on the Anaheim Arena because I think like a terrorist because I talk so much about terrorism. That's a great place to be. There's 18,000 people in that facility. I can control the environment if I'm going to set off a chemical attack. And what are the closest hospitals there? A lot of people are going to go to the closest ones. A lot of them are still going to go to the ones that they're most familiar with. We do have a lot of people that use our clinics, as that's their main healthcare system, and that's where they're going to go. And when those clinics close, where are they going to go? To your ERs. In a lot of the disasters that I've gone out to, it seems like the long-term cares, especially the smaller ones, their goal is to try to transfer that patient off to the nearest hospital. That's what they did in Katrina. Clinics all closed up. I was in Biloxi, Mississippi, 4 hospitals in Biloxi, 3 of them were closed. And all of the long-term cares that were small shipped the patients off to the nearest hospital, and the clinics were closed. So that pretty much overwhelms the system, and I'll talk a little bit more about that. Which agencies might respond with medical resources. Of course, our ambulance would do that. We have a really strong system when it comes to ambulances. We have ambulance strike teams program that's in California, so we can get a lot of resources here, strong in that area. Of course, our paramedic system, I think, is pretty top-notch here in Orange County, too. Home health care, you know, can we tap into these people? Sure, those are resources that we can pull from. The skilled nursing facilities, talked about how a lot of them want to close. We want to keep those places open, okay? We want to have them decompress our hospitals so they can do the more acute care. Public health clinics, community clinics, urgent cares, all of those are the same thing. We want to try to encourage these people to stay open. And for those of you that have been around a long time know that we started Surge OC years ago. We're starting that back up. We're trying to get these people back into the system. So when it comes to resources, being equipment, people, things like that, how do we request that? Well, the affected jurisdiction, what's the first step that they're going to do? The first thing that you should do is what? Does anybody know in here? I know the people from Orange County will. Okay. Yeah, go ahead.
Use what we already have
Yep.
at the hospital themselves. So all the resources that we have on site, we want to utilize everything that we have. And then when it gets down to a point where, and maybe even contracts that we have with outside vendors, we'll utilize them. And when something hits the fan, where we cannot get that information at that point, that's when we'll be seeking out.
Exactly. And that's what we expect from everybody. Try to get it yourself first locally, because when you come to me, I'm going to assume that's already happened. So the way the system works, of course, being in government, you got to have this whole chart and the way everything works, and we have to complicate it beyond imagination, right? Wouldn't be government if we didn't do that. So the affected jurisdiction is going to do just that. If they can't get it for whatever reason, then they're going to go to what's called our Operational Area Emergency Operations Center. And who sits there? There's a couple of different positions up there. One is called the MOHOC. That stands for Medical Health and Operational Area Program. I'm one of those people. There's two of us in this county. The director of EMS is one of them, and I'm the other one. And even though I don't have a MOHOC, reverse MOHOC, I guess. And there's also the medical healthcare branch that sits up in our EOC, and that's usually where the MOHOC sits. So the unaffected local government, state agencies, we don't have any tribal entities here. The NGOs are non-government. We try to seek things from them first. So the operational area is going to look, what do we have here in Orange County that we can supply to you guys if you do a resource request? If we can't get it locally, then our next thing is we're going to go out to the region. The state's broken up into regions. I have a map of that coming up. And then there's some other initials up there. The other thing that you got to love about government is we love our initials and acronyms, lots of them. The RDHMCS or C program is the Regional Disaster Medical and Health Coordinator or Specialist. And they also sit at the health branch up at the REOC, we call it, and that's the Regional Emergency Operations Center. And they're going to go out to their regions and their operational areas and try to get those resources that we're trying to ascertain for you folks. If we can't get it from the region, then it goes on up to what we call the SOC. That's the State Operations Center. Of course, there's a medical health care branch there too. And they're going to reach out to other state agencies if they can't get it. And of course, if the other state agencies can't get it, and we do that through what's called the EMAC, and that's the Emergency Management Assistance Compact. Several states have assigned an MOU, if you will, signed it, and there's an agreement between them that we will share resources back and forth. And of course, the last step is up to the federal government. But through all of these steps, one thing that I want you guys just to keep in mind is the person that is responsible for you in wherever your house is or your facility that you work at is the city. So that would be that mayor. Any other resource is just like what you do if you all understand ICS or HICS, then you know those are resources and support to you. The county is going to support that city. This region is going to support the city ultimately. The state will, the federal government. So in Louisiana, what did the mayor there do? He quickly blamed who? The federal government on the whole mess there. So Bush single-handedly somehow created that disaster, and that's why they were ill-prepared, because of the federal government. Good on his part. I throw this up here because effective and unified national response requires layered, mutually supporting capabilities. And that's from all of those. So we have to have the support of every one of those for us in a big disaster in order for this system to work. And it's all really part of what the feds call the National Response Framework. So the private sector and the NGO, again, is non-government agencies. They're really the backbone behind all of this. All these other components in here, we're here to support you guys. We're not going to go out there and treat patients per se. I mean, yeah, there's DMATs and things, and federal systems or groups that will go out there and help, but ultimately, it's you guys out there that we're trying to support. So here's the map of California, how it's broken up into its 6 regions. We are in what's called Region 1, and in Region 1 that consists of Orange County, Los Angeles, although a lot of people seem to consider Orange part of Los Angeles. I don't, but a lot of government agencies do. We have Ventura, Santa Barbara, and San Luis Obispo. So that's who's in our region. And those are the folks that we would reach out to first. And they reach out to us. The fires that are burning, they're reaching out to us right now for support to go up there and man their emergency operations centers. They haven't asked for any equipment, but they have, other than fire apparatuses. A lot of you that work in Orange County are really familiar with this. Oh, there he is, sitting back there. This is what's called our resource request, otherwise known as our 213RR. We use this for every drill that we do. And it's a fairly simple form, you would think. But since I've been at the county doing this job for 10 years now, we haven't gotten it down right. And some of the things that we will get into our Department Operations Center is they may put the hospital up their name. Well, that's great if I'm reading it because I know who you are and where you are, but if I'm giving that to someone, go deliver this to, Garden Grove Hospital, well, they don't know where that is. So a lot of times the names are missing. The point of contact who we need to get a hold of in order to ask some questions. Because the way these are filled out, you guys are all engineers, so you appreciate this. Does it help you any to look at that form and say, I need 3 generators? No. I think we all know we need a lot more information. I mean, do you want this little portable one I can carry, or do you want this big one that comes on a semi? That's what I get, and I get that in drugs and a lot of medical equipment too. But we've actually had that. Generators, that's all it says. Not much help, is it? So we're still trying to fine-tune of filling those out properly. And you can imagine in something like Katrina, those come in the same way. I know Katrina and the federal government got a big bad rap. And I was there, and I don't care who you are or if it happened tomorrow. There's no way you can prepare and plan and run a disaster that size perfectly. And especially when you get things like resource requests that say that. So who's going to, when it comes to a disaster, where will the quickest help come from? Us, right? We're kind of on our own. I can remember when I used to go out and teach decon classes, and a lot of hospitals would tell me, I don't need those classes. The fire department is going to come and do the decon for me. No, they're not. If there's an event like at the Anaheim Arena, they're all going to be there. And all those people that show up at your facility, you're on your own because those resources are spread thin. Whoops. Okay, so working on solutions to obtain more help. What do we need? One, we need to develop a response plan. The county's part of that, but you guys in your facilities are also part of that. You need to have a response plan. You need to be able to establish partnerships and agreements. Those are like MOUs, Memorandum of Understanding. All of us in the healthcare industry should be working with our closest clinics, our long-term cares, our SNFs. We should be working with our grocery stores. I can remember La Palma, the C&O there, Martha Despodo. She really took this and really started to go big time with it. And she invited the mayor, the city council, the fire chiefs, the grocery store people, all to come in and be part of this pact, if you will, to get to know your neighbor. Because during a big disaster, all hospitals now, who stockpiles stuff, especially pharmacies? We can get it overnight tomorrow, so nobody really stocks anything anymore because we can get it overnight. So if you can't get food, in all disasters, what do you think they're going to take a check from you or a PO or a credit card? No, because they don't work. They want cash. But if you have that relationship with that grocery store manager, chances are you'll be able to go in there and look at him and say, hey, Bob, how you doing? What can we take? And Bob knows you're going to be good for it because he's part of your group getting involved. And that's one of the things that we're working on today is trying to re-energize that and getting all of these people back together. We need to conduct drills. And I know everybody says, oh, I don't have time for this. You know, I don't want to do it. Thank God for Joint Commission. If it wasn't for them, I don't think I would be out of a job because nobody would need to do any drills. So I'm glad for Joint Commission. I know you're going to throw things at me and everything, but I think if it really wasn't for, I think we all care, and everybody in this room probably does, but you know, hospitals are in business to make money unless you're a nonprofit. And disaster doesn't make money, especially on the preparedness side. But we need to conduct drills, mainly because Joint Commission requires a couple of them a year, right? We need to identify the supplies and resources that we currently have, and we need to network with all of those people that I just talked about. So there's really 4 things that we can look at here. And you know, some people in this room I know fit this category like me. The nose especially fits, right? And the hair is kind of close. Glasses now that I'm older. So alert, access, analyze, and ask. So what do we do on the alert phase of this? Well, we know that we need to alert folks such as us, EMS, Emergency Medical Services, because that's who's ultimately responsible for all of you guys when it comes to medical needs if you're a hospital with an emergency room. If you're a clinic, a long-term care, or if it's a non-medical issue, it is your city that is responsible for you. We only take that medical side if you're a hospital with a receiving center. So, of course, we would have to be notified. Any transportation providers that might be out there that you need to get in contact with, you should have agreements with them. You can also do that through us if you're a hospital with an emergency room. Hospitals and care facilities, again, I don't want to keep harping on it, but having those agreements with those folks, knowing who's in the area. I know there's a gentleman in this room that once told me, I will supply the clinic near me if they say they're going to stay open. Can I mention who that is, Kirk? No, okay. Regional Disaster Medical Coordinator, that I'm one of those, but know who that is. And in our county, how many people, by the way, are not in this county, in Orange County? Oh, good percentage of the room. I think we're very fortunate in this county that we have a very tight-knit group. We all know each other. We can call each other up and recognize our voices. I bet you everybody in this county has me on speed dial in their phone, and I have all of their cell phone numbers too. And a lot of times things happen and they kind of forget to call me, and they look up and, oh, shoot, I forgot to call him. And that's okay, because I know we get busy in disasters. So looking at that regional disaster program, also looking at the state EMS authority and what they can do for us. And that's usually done through the local EMS. And how do we access all of this? Problem with medical transportation in the county plan, who do you think would be, besides an ambulance company, what do you think would be a good resource to get transportation needs done? Yeah, that's Orange County Transit Authority. The problem with that is everybody uses them. They are in everybody's plan in this county as a transportation need. And we're all relying on what? We're relying on that driver that says during the big earthquake, oh yeah, I'm going to abandon my family and my wife and my kids and leave them at home, and I'm going to jump in that bus and drive around and pick people up. No, it's no different than some nurses. We know in the 71 Kalinga earthquake that several nurses left their patients, and they looked to the next nurse, here, you take care of my patient, I'm going home and check on my family. Well, we know through that process that a lot of people aren't going to show up to work or leave. So we really got to look at that as a whole and how we can get things here. And that applies to resources. Hospitals, staff's going to drop down and the census is going to go up, right? So we really got to be working closely with which agency? Licensing and certification, because we got those patient-nurse ratios that we got to deal with. Our clinics and urgent cares. If we have relationships with these people and they know what this is all about and we bring them into a program, they're more than likely going to stay open than close because they feel part of a system. So that's what we're doing now and building that back up as well too. So you're going to hear a lot more from that gentleman that's sitting in the back there, Jason Beach. He's been hired to do nothing but work on our healthcare coalition outside of the hospitals. So he's going to be working with those nursing facilities and home health care. We need to look at that too because there's a lot of people out there that go out and do home health care. And we want to keep them there because we want to keep them out. Dialysis centers. How many people do we dialysize in this county? A lot. And if they all close down, where are they going? Nearest hospital, right? And can you guys take those in? Probably not. Last one is analyze. So what we want to do is just those outright requests that I talked about in the resource request, make sure that we get those filled out properly. Take a look at them, make sure it makes sense, that you're ordering a 6,500K generator, not just write generator there. That you're thinking about the process, well, I have that generator, but how am I going to fuel it? So be thinking about that when you're writing your resource request. How are you going to take care of that? Or do I need transfer boxes? Do I need extension cords to go with it? Medications, if you're ordering a medication, think of some alternatives in case I can't get it. If you order something like Cipro, it's like, well, you got to put the dose and how many you want in there instead of just saying Cipro. But if I can't get that and there's an alternative already on that resource request that I can look at and say, oh, look at that, they're taking doxycycline if I can't get Cipro. That means I don't have to call you back, hoping you have a phone number there, to ask you, will you take this drug in place of it? If it's already there, it just helps with the process. And that's kind of what planning's all about. I know a lot of disasters, well, I should say disaster drills in this county. Planning is a very important section within our Incident Command System, or HICS, Hospital Incident Command System, that we need to look at, and those planning people need to be planning ahead for all of this. Everybody remember the H1N1 crisis? We couldn't get N95 masks. I tell this story all the time. Couldn't get them. All these planning should have been doing all of this stuff, thinking of things. And then another person who came out of the blue that, and now I can find out the answer to my question, that really impressed me. He was really thinking out of the box, and that's Kirk again. He goes, I'm going to try to get some from China. Who thought about that in this room? Were you ever able to get them from there? Yeah, see? Now I know the answer to that. Oh. Do you? I mean, that's really thinking outside the box, because they probably make them for everybody anyways, right? Okay. ask here. So we want to ask for our local resources first. As David said, you know, he hit it right on the nail, right on the head. We got to try to get it locally first, through our sister facilities, through our network that we have. If we can't do it through that, then you would reach out to me as the Mohawk. I would try to get it through our other resources, or if I have it at my warehouse, and then move on up the chain to other counties, up to the region, and of course up to the state. Now you have a lot of tools out there too. Believe it or not, when I was in Katrina, you'd never guess how I communicated. It was by courier pigeon almost. A guy in a car came by to where I was providing medical care. The place that I had was a shelter that housed about 1,800 people. I treated 300 patients in a 24-hour period, and then we had public health people in the same place that were taking care of people that had dysentery and things of this sort, and the special needs type folks. I communicated by someone coming by with a car, and we passed notes back and forth because they were so ill prepared they didn't even have a satellite system. I did. My DMAC group went out there. We set up our portable satellite machine, and away it went. But we couldn't call anyone, or at least in Mississippi, Biloxi, because they didn't have satellite. Luckily, the repeaters came up on AMR ambulance, and we used their ambulance radio to talk to them. But in this county, we have a whole bunch of redundant systems. We have ReadyNet. I don't know, some people, it looks like they know what that is. That's our main source of communications with EMS and all the emergency departments in this county. LA has it, a lot of counties in the state have it. And it actually runs through a satellite system. So if the entire infrastructure communications-wise collapsed, you know, unless the satellite fell out of the sky, more than likely it's going to work. Now there's weather conditions and things like that can disrupt it, but it's not reliant on our normal means of communications, and assuming we have power to it. But I think all hospitals have some sort of backup power. Here is hospital emergency alert radio. That is a radio that does not rely on repeaters. It's a line of sight radio. If you understand radio communications, it's simplex. Loma Ridge, our communication center, sits really high up on a hill. And again, if you understand communications, you know the higher the antenna is, the greater you're going to be able to receive. So they can talk to every one of the hospitals in Orange County. At my EMS office, if it's still standing, I will be able to talk to every hospital with the exception of 1.5. The one is Laguna Beach. It's just because of the mountains I can't get there. And the half is La Salle. Anyone from La Salle here? I hit them about half of the time because of the distance. We also have amateur radio group. We have a group in this county that is dedicated to nothing but doing amateur radio stuff with hospitals. That's all they do. These guys that's their hobby. They love doing it, and they can go set up portable repeaters and things of that. We've got telephones and cell phones we can use, and of course all those other things there, internet. CAHAN stands for California Hospital Alert Network. They just revised that system, but that is a notification system, if you're not familiar with that. That is a free system for anybody in California to use. So if you're not familiar with CAHAN, you can Google that and get on that system, and you would work with your local EMS agency to take care of that. And of course, we talked about sat phones. So what's next? Well, we want to begin planning today. And as I said, one of the things is trying to get our healthcare coalition together, bring that back into where we started it several years ago. Some of your other counties here may already have something similar to that, but we want to be able to know those people, be on a first name basis with them, and that's one of Jason's jobs. So networking, again, that's doing the same thing there. So know the systems and resources, and if you have this strong network, you're going to know what that is, right? You're going to know what I have at my warehouse. We have a new system now that hospitals can actually go out to the website and see what my inventory is at my warehouse. So if you need a ventilator, you're going to be able to look at it and you're going to see that I have 248 ventilators. And as those start disappearing because people are requesting them, then you see what's left. One of the things you really need to know about resources is don't ask for it unless you need it. Because it's like stealing from Peter to pay Paul. If David decides, well, you know what, I may need these, so let's order 50 of them, and somebody else needed them because someone's standing there with a bag valve mask, and those are just sitting there, not a good thing. And of course, drilling, and by practicing. We were just talking about this morning at our net meeting. I have 10 decon trailers in this county, and of course you guys don't have any, but the hospitals that have them, they're not really going out there and practicing on it. Look at all the equipment, and you all fit in this no matter which county you're at. You've all gotten, I bet, is anyone in this room not have a decon tent at their hospital? So everybody in this room has a decon tent in this hospital. How many of you can honestly say, I can go out there and set that up and have it functional 100% the way that it's supposed to be? See, about half the people in this room, actually a little less than half. And if you weren't there, those that raised their hand, is there somebody at your facility at night that could go do that? About 4. And we've had these decon tents for 10 years now. And only 4 people tonight in this room could have someone set that up. Practice, right? And I know it costs money to do all that because you have to pay staff to go do it. And a lot of them just, well, that's not my job. So it makes it tough. So what are the duties? One is we want to develop and maintain plans. And another reason, why do we write plans? How many people have disaster plans in here? We all do, right? Because it's required. How many of them only read them when you have to revise them? Yeah. How many of your staff in your facility knows where those are and could go pull them out during a disaster? We want, and that all boils down to is we need to get management. And I know I don't have any CEOs in here, right? We need to get them to support the disaster people. And a lot of times the facility people are the disaster coordinators. It seems like whenever we really start going to town and supporting all of this is after we've had a disaster, right? When I worked at Western Medical Center, now Orange County Global, I remember Dan Brothman, the CEO, came to me after 9/11 and said, I don't care what it costs. I want this place the best prepared hospital in Orange County. I spent $100,000 of his money, and that was before grants came about. Liaison with other agencies. What's that? Yeah, then all that money came out, and I'm sure he's probably kicked himself in the rear several times after that, but I mean, it wasn't immediately, but it was pretty close. We want to liaison with other agencies, and we do a great job of that in this county. We meet monthly, as a matter of fact. We want to support our disaster and emergency communications. I think in this county, we're really ahead of the game on that because we do have ReadyNet, we have here, we have our amateur radios, we have a really robust 800 system, and a lot of hospitals have gone to satellite communications now. Train medical and health providers in HICS. Anyone here not done that? That's a mandate from the federal government. If you want federal reimbursement for something, your people have to be ICS trained and HICS trained. So most people do that. And plus, it's a great little system for those of us that don't do this every day, like the fire department, who live, eat, and breathe this stuff. They've really done a nice job of making it pretty simple. Support community mitigation and education. Again, that's by getting our partners together, working on that, because there's nothing like mitigation to prevent something from happening. How many of your facilities in your lab is the testing stuff secured? Bolted down, strapped down, something like that, So when we have the big earthquake, it doesn't all fall off the shelves. A good way for mitigation there. Develop and maintain those MOUs, if you will, Memorandum of Understandings. I think everybody probably knows what those are. We want to work with our vendors. How many people have an agreement, either written MOU or verbal agreement, with Cardinal or what's the linen company? Mission, and what's the other one? And thank you, Angelica. They're gonna supply stuff to everybody in California all at the same time. I don't know how they're gonna do that, but everybody's got the same agreement with the same company. Attending the committees, and again, that's time taken out. But again, I don't want to keep bragging about Orange County, but we do this monthly. We drill twice a year. We have tabletops at least once, if not twice a year, and we have really good participation from the hospitals. And we're trying to build that up with our coalition. So what resources are going to be available? Again, we talked about ALS and BLS. We got that ambulance strike team concept. We've got, again, the state loves, well, government in general loves acronyms, so we have what's called DMSUs. Those are disaster medical support units that support this ambulance strike team concept, that they come out and bring groups of ambulances to help us. Yes, and it's also federal too. AMR has the contract for the federal government to do that. Home health care, I think we need to start looking at those folks because they have a lot of resources that can probably help us. Plus, we want them to keep those patients, if they can stay home, at home and not in our facilities, right? Skilled nursing facilities, same thing. Talked about that already. We want those doors to stay open. In fact, we want them to decompress the hospitals and take some of those folks in so that it can make more room for you guys. In Biloxi, you know, with one hospital open, the whole parking lot was full of people. They were treating people outside in the parking lot. There was no room inside. The hallways were, you know, if Joint Commission ever came in there, they'd probably be a ton of violations. Gurneys on both sides of the hallway. Urgent care centers, there's another great aspect or people to plug into if we can have them keep their doors open to help decompress. You know, those minor emergencies can go in there. Those lacerations and things from a big earthquake can go into those folks instead of coming into our emergency rooms. And I know with EMTALA, we can't really tell people, well, hey, why don't you just go down to the clinic down there because they're probably going to suture you up faster than we're going to see you here. But I think it wouldn't be an EMTALA violation to put that sign saying that out by in front of the parking lot, would it? Out in the sidewalk in front of the parking lot. Yeah. We'll see how that works. Yeah, yeah. Physicians, nurses, and medical technicians, you know, we have a couple of systems in place to bring these folks in to help. And that's through what's called our disaster healthcare volunteer system and our medical reserve corps. So those are folks that can come in for manpower to help. Again, we want to look at equipment and supplies to help stabilize the situation, if you will. So risks in Orange County are going to be all of these. Kind of talked a little bit about some of them. The one that disappeared up there is the nuclear generating station. So the voters decided that it was too much of a threat, so they closed it down. The fuel rods are still there. If you think they're not, they are. So that is still a threat. In fact, in some cases, maybe a little bit more because they're in a pool. Instead of being spent, they're full. But we don't have that worry that that plume is going to go as far as it did when it was an active generating station. Mass evacuations, that's not really an evacuation there, but if we go back to the Anaheim Arena, 18,000 people, and they all come running out because they think they've been sprayed with sarin, it could look like that at your hospital coming down. Anyone see the pictures of Joplin? There's a facilities guy that describes that picture right there, walking down the street trying to get to their facility because the lights were on. kind of like Motel 6. Immediate health care and catastrophic emergencies. We want to look at our communication system, our hospital infrastructure. We know that people are just going to show up. They makeshift ambulances. They did that with what's the place that blew up? That guy that came with a truck with a fertilizer? Oklahoma, thank you. Phew. See what happens when you get old? Yeah, and the majority of patients were transferred by Good Samaritans, if you will. So they transfer those people for us, and they just showed up, and that's unannounced at the hospital. Looking at other things is that on the infrastructure is road access. During a major earthquake, we know we're going to have big problems with our roads trying to get to and from places. Well, that's traffic, but yeah. Actually, the traffic might be better, huh? We know that the facility structure, I'm sure Oshpod's going to talk about that. But we have to look at that. Is it safe to stay in that building? And that's beyond my expertise. Staff availability, talked a little bit about that already. Staff that's not going to come in or may leave. Water, power. Is the water safe? During a big earthquake, we may have water pressure, but we don't know if it's safe. Can we use it or can we not use it? So things to think about. Security. Who's got enough security to lock down your facility? Anybody in here? You do? Wow. Which hospital are you with? Oh, well, there you go. Now Chalk is pretty good here, but simply because that's a pediatric hospital, they have security almost at every door. But for most places, other than Chalk and some people have, how many people here have just one security guard on duty at a time?
I think we do it quite a few times.
Yeah. Your medical gases, how are we going to take care of that if we lose that and we can't get oxygen? So a whole bunch of things to think about there. What's that?
314 on staff.
Oh, security? Jeez. Wow. And we talked about all these communication systems. If they're broke, they're not going to work, right? And you have to revert something like we did in Biloxi, but here in Orange County, we know that's not going to happen. Also look at your spontaneous responders. A lot of times you get a lot of volunteers that come in that want to help, that you don't know if they really are a doctor or a nurse or a security guard or a police officer. I could tell you lots of stories about that from Katrina, but I don't have enough time. The first 24 hours of a response is the most chaotic thing that you can imagine, because things are so fluid and information's coming in and misinformation's coming in. It's very hectic to try to sort out what's right and what's wrong, what's real, what's not real, and trying to get your facility operational. And that all boils down to one thing that we call situational awareness. And a lot of times you can't really believe what the news tells you either, assuming that's going to be up and running. But I talked about the roads. When I went to Katrina, FEMA got a lot of bad press out of that. Where are they? I can tell you that I would drive down roads and I had to rely on my GPS unit because signs weren't up. They were down. You couldn't see what street you were on. And then you run across a street that looks like that. And then what do? You got to try to go someplace else. You know how your GPS keeps wanting to route you back? You have to listen to that annoying, yeah. So you have things like that, and that limits resources from getting to you. Northridge, anybody remember that? Anyone from Kaiser? I just had to throw in. Oh, good, I'm glad he left. Why did Kaiser fall down? Don't they always say they're the best facility? Yeah, that's why I'm glad he's gone. All of you? Yeah. So just a couple of pictures. I wanted to throw a couple in here just because, it is devastating. In Northridge, what's that? Oh. Oh, so Okay, so, well, nobody got hurt. Yeah, isn't that sad? I guess some. He didn't work there then.
Before Oshkosh was created, that was the reason Oshkosh was.
Oh, really?
That hospital was the reason Oshkosh started.
Wow, look at that. And I was making a joke out of it. So we created a job. There we go. You're welcome. Well, created one for me too, and then back there, if it wasn't for disasters, we wouldn't have jobs. So in Northridge, it was a 6.7, and that was some of the devastation just from a 6.7 that lasted only about 10 seconds. There were 57 deaths, 9,000 injuries, over $50 billion worth of damage, and of course the transportation system failed, and we know why. Some pictures from Joplin. I don't know if all these are out on the internet, but there's great stories from Joplin. I talked to a lot of them, but you can see the glass is all missing out of it. You got this gentleman taking pictures here. Always someone taking pictures, right? Some of the cars, what they look like outside, and look at the roofs there. I mean, blew them right off. The inside of the place, can you imagine working in something like that? Yes, sir. Yes. Yeah. Some more pictures inside, patient care room in there, you know, trying to work in that mess. And my favorite part about this picture, since I ride a motorcycle, yes, still on the kickstand. The only thing that you know, wow. Everybody else comes out and looks at their car and says, I'm not going anywhere. Guy hops on his bike and takes off. Yeah, yeah. Right. So lessons learned from Joplin. Ride a motorcycle. Maintain close relationships with your neighbors. And we talked a lot about that. Train on the art of triage. It was really surprising to listen to these people talk at the California Hospital Association conference. You know, we all use triage here all the time, and we train in it all the time, but it was seemed like a new concept to them. Integrate incident command system and review it regularly. I mean, how often do we talk about that? Implement regular disaster drills. Formulate plans for patient tracking and supplies. They had a hard time keeping track of their patients. You got to remember, in something like that, your computer system's down, and we do everything electronically now. Nothing's done on paper. So you got to revert back to the manual system. So imagine that, you know, who's in my hospital? And if those charts are all thrown all over the room, you saw the pictures of it. So we got to try to track who was there and where are they now. Look at EMS participation in, you know, the emergency operations centers. Arrange post-incident debriefing and learn to accept the fluidity of the disaster. And that's the biggest thing. And I've been involved in all of those. And I can tell you the first 24 hours is very chaotic. And anything the size of Katrina, it's constantly changing because of the size of it. I wanted to throw some other statistics in there as well too, because we had this in 2002, the Placentia train collision. We learned a lot from that, and that was something relatively small in this county. But there were 163 total patients that we had. For whatever reason, the majority of them went to one hospital. And we learned out, you know, why that was. But 19 in the triage system, 19 of them were considered immediate patients. 67 were delayed, and 76 were minor, and of course one died from that. No, I can. It's the long and short story of it is they were running this like the way that we drill. And the county is set up in a drill system with the colors. Remember the colors? and they pulled everything out of that colored net. And even though, one net's over here and one's over here, and the incident was in the middle, they started sending everything that direction when they should have gone halfway this way and halfway into the next color. So it was a mistake that was made up at Loma Ridge. Can you erase that from the tape, please? Thank you. And of course, Madrid, all the stuff that happened there, 80% of victims treated and were released from there. 19% were admitted to hospitals. 1% were dead on arrival. The first victims arrived in 15 minutes, and that's what I think is amazing. 15 minutes after. I bet you some of the hospitals that got these patients didn't even know what happened. They just saw the patient show up there. Arrivals peaked between 60 and 90 minutes. 62% of the victims were triaged to the EDs within 3 hours. 64% went home. POV transported victims, 6% admitted. EMS transported, 64 of those were admitted, and so on. The high school thing, I actually had my mental health person there from my DMAT team, but there were 4 triage areas, 160 patients were triaged, 24 patients transported, 6 were hospitals were utilized in that particular incident. Oh, that's the one that was Madrid. That was a high explosive. Everybody probably remembers that one, but approximately 1,430 casualties, 177 were immediate, 14 in-death hospitals or in-hospital deaths. So 966 transported to 15 hospitals. Take 15 hospitals, divide that into 966. Can you guys handle that? I know he can because he's got 400 security guards, but imagine what the rest of the staff must be like. How many beds are at your facility? Well, there you go. Yeah. In the hospital study, there were 1,800 beds at one of the university teachings, 312 casualties, 272 of those over 3 hours, and the mean age was 32. So, disasters, the reason I put all of these in here is disasters obviously are going to overwhelm things no matter what they are. We do have a federal response plan that falls under Department of Health and Human Services when it comes to medical stuff. And that particular plan is to help all of you guys out there on the federal side of it. So we have our county side, we have our state side, and then we have our federal side. And there's 28 different agencies that work within this federal response plan. They all have numbers. They're called, from a county level, not a whole lot, but since I'm involved with the DMATs, we train quite a bit with it. But we fit in 8 under Health and Medical Services, and that's the one that Health and Human Services are in charge of. So that's the kind of the federal structure. I talked a little bit about NDMS already at the beginning of this. It's the National Disaster Medical System. Almost every hospital in this county belongs to that system. I don't know if you guys do in the other counties, but when you sign up to belong to that system, you're just agreeing to take patients in either through wartime or through major disasters. We actually activated the system for Katrina. And they guarantee to reimburse at 110% of Medicare if the patient doesn't have any insurance. Yeah. So when requested, they're going to supplement local resources. We can move in there with DMATs, as I talked about, which is one of the things that I belong to. It's a group of medical and non-medical people that go out. As I mentioned in Katrina, we treated 300 patients in a 24-hour period. That's a lot of people. But you got to remember, we can turn that around a lot faster than an ER because a lot of stuff we don't have. So we just do the best that we can and move them to definitive care if we have to, or try to take care of what we can and stabilizing them and letting them go back home. So normally we're there to manage 250 patients. That's our goal. So we exceeded that in Katrina. All right.
Good job.
3 minutes for questions. None? Well, okay, thanks for, yes.
Mention any resources, any direct cash locally for any of the counties for the most part? Are there medication caches for the federal cash, local?
Yes, there is. The question, if you couldn't hear it, was, is there any medications and stuff locally? And I can't tell you where it is, but there is. It's called the Strategic National Stockpile, and there are medications in that. But I can tell you that funding over the years has been dropping because we haven't had any big events. So that drops, so it's not quite what it used to be, and that's because they don't have the money to replenish it. So a lot of this stuff expired and we had to get rid of it, but there's still a lot there, so yes. And of course, the state of California, all of their stuff, they've gotten rid of all of it. All those alternate care site caches that they used to have in California, that all disappeared with the new administration. No. We have the state during, when we had all this, the state had all this money, they bought a couple of 200-bed hospitals. That, the answer, do we still have that? Yes and no. It's still in California. It's really been given back to the company that we bought it from, or California bought it from. They now manage it, and the agreement with it is that we have first access to it whenever we need it, and of course, unless it's deployed someplace. But and they can only they have to leave one here at all times. So the other one, the agreement is they could take wherever they want and set it up and charge or whatever the company does. It's Blue Med.
Is that kind of what the picture you showed?
Yes, yes. The very beginning of it, yeah.
Are you involved in GPRI, Global Theft Reduction Initiative, from the National Nuclear
No,
for high ionizing radiation system?
no. Never heard of it until you just mentioned it.
Program.
Is it? Okay. Jason back there, I'm sure took note, jotted that down. Okay. He's got a good memory, I don't. Any other questions? Nope?
Thank you, Mike.
Okay, thank you. Oh. Are you next? Who?